Hello, my name is Rebecca Lopez. My team is Abrupt relaxed of ALK positive lymphoma after discontinuation of Crizotinib. Definition: Crizotinib is a targeted therapy. This drug is an oral inhibitor of tyrosine kinase receptor. For more details, see the How this drug works section below. It is used for the treatment of patients with metastatic or locally advanced non-small cell lung cancer, caused by a defect in a gene called ALK anaplastic lymphoma kinase. The cancer must be ALK positive according to an analysis approved by the FDA.
L'objectif de cette recherche était justement de voir parmi les patients qui avaient reçu une immunothérapie, quels étaient les patients qui avaient bénéficié de ce traitement à partir d'une étude très approfondie du système immunitaire du sang, donc à partir d'une simple prise de sang. Les patients qui ensuite ont bénéficié de cette immunothérapie avaient un taux de lymphocytes, donc des cellules pouvant reconnaître le cancer, qui était plus élevé des patients qui n'ont pas retiré un bénéfice, que certaines cellules, notamment les cellules qui sont capables de présenter un antigène, de flanquer un danger au système immunitaire, étaient plus élevées, plus activées chez les patients qui ont répondu. L'idée d'utiliser des biomarqueurs, c'est justement de prédire les patients qui vont retirer un bénéfice avec un certain degré de confiance. Donc, pouvoir réaliser une prise de sang, par exemple, avant traitement, qui puisse diriger vers un choix thérapeutique, c'est très important.
How Crizotinib is given. Crizotinib is a capsule that is taken orally twice a day. It can be taken before or after meals. 1. Take Crizotinib exactly as directed. 2. Swallow the Crizotinib capsules whole. Do not crush, dissolve or open the capsules. 3. Do not change your dose or stop taking Crizotinib unless your healthcare provider tells you to. 4. If you miss a dose, take it as soon as you remember. If you are very close to your next dose, waiting 6 hours. 5. Taking only the next dose at your regular time.
In the future, I think the EGRTK we had two the question and two the question needed to the answer. First, how to treat them, how to in the second generation, the third generation osimertinib. So I know in the near future, maybe we will develop the so-called fourth generation is a TKI, and this TKI could cover all the C797S and another pathway. So this is one point. The second point, in the future, maybe we could combination the strategies to overcome the resistance, such as we could add the anti-angiogenesis and also the chemotherapy and another overcome the resistance. This is the future. I think this also had some promised result. So EGRTK is the revolution in the lung cancer treatment. They have prolonged the patient the survival and increase the quality of life. So I think this is the revolution. Also, I think that in the future we could develop more and more the effectiveness and more broad anti-tumor activity the EGRTK. And that time we could prolong patient over survival, maybe 5 years, 10 years.
Precaution to be taken when following a treatment with Crizotinib. Well, before starting Crizotinib treatment, make sure you tell your doctor about any other medication you are taking including prescription, over-the-counter, vitamins, herbal remedies, etc. Do not taking aspirin or products that contain aspirin unless your doctor specifically allows it. 2. Do not get any type of immunization or vaccination without your doctor's approval while taking crizotinib.
Okay, I think it's very interesting. So far, we have the experience in the advanced disease. So exciting the result, we have prolonged the patient over survival. So in the clinical practice, we want to know, could we using this the EGFR in the adjuvant setting? So last year, we have the very, very important clinical trial, this so-called adjuvant trial. The adjuvant trial is using the gefitinib in the adjuvant setting for the resected local advanced disease. So the results show the DFS prolonged about 10 months. This means the patient reduced the relapse 10-month times. So in China, so this is very interesting. So most the thoracic surgeon, they want to use EGFR as the adjuvant setting. And the patient also agree, also like the using the EGFR in the adjuvant setting. So this is why we think that in the future we could more the data using the EGFR in the adjuvant setting. We are also now the third generation, the EGFR as the adjuvant setting. Now this clinical trial had enclosed. Now we are waiting the final result. So this is in the future, the EGFR could be used in the adjuvant setting. In the adjuvant setting, we are using for the patient only the lymph node metastasis, not for the early stage the non-small cell cancer, because the early stage the no lymph node metastasis, this patient live very, very long. The 5-year the survival about 70%, over the 70%. I think this patient we don't need any the adjuvant treatment. So we are only using the adjuvant treatment, the TKI in the lymph node metastasis resected non-small cell cancer. And also the drug in all the clinical trials about 2 years. So I think could we short and longer the drug, we need more the clinical trials.
Continuation, if you are pregnant or think you may be pregnant, tell your healthcare professional before starting treatment. Crizotinib is a drug classified in category D. It can mean a risk to the fetus. Women who are pregnant or who become pregnant during treatment should be informed about the possible risk to the fetus it takes.
The question has recently been brought up, well, now that we have new ways to treat systemic therapy, using tyrosine kinase inhibitors, for example, does that old paradigm still apply? Does it matter? And so there was a clinical trial called Carmina that tested the notion whether a cytoreductive nephrectomy added value when it was added to systemic therapy using a tyrosine kinase inhibitor, in this case, sunitinib. And the bottom line is that Carmina showed there really wasn't a difference, which frankly was a shock and a surprise to most of us. Most of us assumed there would be some difference, and it turns out really there wasn't. And so the issue now is, how do we now integrate the findings from that trial into our old paradigms? And how do we readjust the way we think about the role for cytoreductive nephrectomy in this space? And the bottom line message essentially is that it's still going to boil down to patient selection. So what Carmina tells us is there isn't quite as much of an advantage to surgery as there was before. So you need to be particularly selective about who you choose to do a cytoreductive nephrectomy in. So we should not be using it willy-nilly. We shouldn't be using it in the highest risk of the highest risk people. We should not use it in people who have rapidly progressive disease. Don't use it in people who don't have resectable disease. And essentially, don't push the envelope. We used to push the envelope on purpose because we thought we were adding survival value. Now that's not as clear, so there is no point pushing it the way we used to.
Conclusion: during